Bismillahirrahmanirrahim. Assalamu alaikum. My name is Asim Yousaf and my class registration number MLT120192001. We is MLT a semester student from Cohort University of Science and Technology. Today my presentation topic is about Hodgkin lymphoma. What is a lymphoma? Lymphoma is a clonal proliferation of lymphoid cell of various degree of maturity within a single organ. Cancer of the lymphatic system. They may be nodal 2 or 3 of lymphomas which rise from lymph nodes, extranodal spleen, skin, stomach, intestine, mediastinum, brain. Classification of lymphomas. Main types. Hodgkin lymphoma, non-Hodgkin lymphoma, other. Non-Hodgkin lymphoma has two subtypes, B cell lymphoma and T cell lymphoma. Definition of Hodgkin lymphoma: a new plastic transformation of lymphocytes, particularly in the lymph nodes, characterized by the presence of red Sternberg cell on histology, treating an elderly patient to contiguous lymph nodes. For example, Hodgkin lymphoma that starts in the cervical lymph node may spread first to the supraclavicular nodes, then to the axillary nodes. Red Sternberg cells, hallmark of disease, cells with mirror imaging nuclei and prominent eosinophilic inclusion-like nuclei, red Sternberg, large 15 to 45 micrometers, multiple multilobulated nuclei, clonal in origin, arises from germinal center B cells. Histological classification of Hodgkin lymphoma. First one, non-lymphocyte predominance. Hodgkin lymphoma is 5% of cases as good prognosis. Second one, second is classical Hodgkin lymphoma. Hodgkin lymphoma is more common as four subtypes. Number one, nodular sclerosis Hodgkin lymphoma. Second, lymphocyte-rich classical Hodgkin lymphoma. Third, mixed cellularity Hodgkin lymphoma. Fourth, lymphocyte depletion Hodgkin lymphoma. Nodular sclerosis Hodgkin lymphoma is by far the most common female than male. Most common 70% of cases, excellent prognosis, anti-mediastinal. Lymphocyte-rich classical Hodgkin lymphoma has very good prognosis. Mixed cellularity Hodgkin lymphoma. Plasma cell, histiocyte, and eosinophilia. Lymphocyte depletion Hodgkin lymphoma. They are least common. They are most aggressive. They are poor survival. Histology. Lymphocyte predominant has the best prognosis. Lymphocyte depleted has the worst prognosis. And orbital staging of Hodgkin lymphoma. Clinical classification. First stage. Lymph nodes in one region or a single organ or site. Second stage. Lymph node of two or more regions on one side of the diaphragm above or below. Third stage, involvement group of lymph node on both sides of the diaphragm, including the spleen. Fourth stage, multiple and disseminated involvement of extralymphatic organs and tissues such as liver or bone marrow. Some are etiological factors of Hodgkin lymphoma. Number four, certain viruses, Epstein-Barr virus, human immunodeficiency virus. Second factor, weakened immune system. Inheritance conditions, certain drugs used after an organ transplant. Third factor, age. Hodgkin lymphoma is most common among teen and adult age 15 to 35 years and adult age 55 years and older. Fourth factor, family history. Family member, especially brother and sister of a person with a Hodgkin lymphoma or other lymphomas may have an increased chance of developing this disease. Clinical presentation. There are two types, general symptoms and local symptoms. General symptoms observed almost every third patient of Hodgkin lymphoma. These include fever, sweating, especially at night, weakness, fatigue, weight loss, itch skin, headache, pain in the bone and joint. Local symptoms. Due to the location and the size of the affected node, lymph nodes, and other lesions in various organs and tissues. Clinical presentation. Enlarged, painless, rubbery, non-erythematous, non-tender lymph nodes are the hallmark of disease. May become painful after drinking alcohol. Patient may develop beef symptoms, systemic symptoms, which are drenching, night sweats, diaphoresis, 10% weight loss, fever. 25% have B symptoms, although pruritus is common in the disease. It is not one of the B symptoms. Cervical, supraclavicular, and axillary lymphadenopathy are the most common initial signs of the disease. Lymphadenopathy, cervicular and supraclavicular, painless, non-tender, frame and rubbery, hepatosplenomegaly, cause dyspnea, hypoxia, pleural or pericardial effusion, hepatocellular disinfection, bone marrow infiltration, anemia, neutropenia, and thrombocytopenia. Disease below diaphragm is rare, only 3%. Emergency presentation infection, SVC, obstruction, facial edema, increased GVP, and dyspnea. Systemic symptoms, B symptoms. Important in staging, unexplained fever, 39 degrees centigrade, weight loss 10% and 3 meters, drenching, night sweat, immune system abnormalities, energy to delayed hypersensitivity, scan test, abnormal cellular immune response, decrease CD4 and CD8 ratio, reduce natural killer cells cytotoxicity, cervicular lymph node involvements. Long-term complications, secondary malignancies, acute myelogenous leukemia, non-Hodgkin lymphoma, carcinomas of breast, lungs, and thyroid, short stature, hypothyroidism, sterility, dental caries, subclinical pulmonary disinfection, ischemic heart disease. Diagnostic procedures, excisional biopsy, light microscopy, immunocytochemistry, molecular study, chest X-ray, mediastinal mass, CT scan, chest, abdomen, pelvis, blood CP and ESR, LFTs, bone marrow aspiration, serum copper and ferritin, bone scan, gallium 70 scan, FDG and PAT. Diagnosis. An excisional lymph nodes biopsy is essential first step in a diagnosis. A biopsy is the only sure way to diagnose Hodgkin lymphoma. The biopsy can be excisional biopsy and incisional biopsy, a fine needle uh, aspiration usually cannot remove a large enough sample for pathologists to diagnose Hodgkin lymphoma. After that, the most important step is to determine the extent of disease because the stage will determine the nature of the therapy, that is, radiation versus chemotherapy. Investigation used for staging. Chest X-rays. X-ray pictures may show swollen lymph nodes or other signs of disease in the chest. CT scan, chest, abdomen, and pelvis. CT scan is sensitive enough to detect any abnormal node. MRI, PET scan, LP for CSF cytology, if any CNS signs. Lymphogenography and laparotomy are no longer used for staging. A bone marrow biopsy is used when first B symptom and second stage 3 and 4. Abnormal lab tests don't alter the staging of the disease. CBC, anemia and high WBC, eosinophilia is common, LDH high, poor prognostic picture, ESR high, poor prognostic picture, LFTs help determine the test for liver biopsy. After lymphoma is diagnosed, a variety of tests may have carried out to look for specific features characteristic of different types of lymphoma. These include immunophenotyping, flow cytometry, FISH testing. The classification of lymphoma can affect treatment and prognosis. Classification systems generally classify lymphoma according to whether or not it is a Hodgkin lymphoma, whether the cell that is replicating is a B cell or B cell, the site that the cell arises from. This is all about the Hodgkin lymphoma. Thank you.